Good afternoon, dear committee, dear audience. I would like to present my PhD thesis. My name is Eszter Virág-Tulassay, and I am working as a resident doctor at the Department of Orthopedics at the Semmelweis University, and I am a second-year PhD student. My vision is that in the future, shoulder dislocation will not be a long-term limiting injury for young people, so my mission is finding the best choice therapy for each patient with anterior shoulder dislocation. Because of that, we have two specific goals, and I would like to present my first one, that is Bankart surgery is the most effective therapy for first-time anterior shoulder dislocation. Shoulder dislocations are about the 50% of all joint dislocations, and 97% of these being an anterior one. Acute shoulder dislocation are associated with significant pain and numerous tissue injuries, but the problem is that the most appropriate treatment option is unclear. Maybe conservative treatment is enough, for we need a surgery, a soft tissue surgery that we call Bankart. So our aim is there are currently no international recommendation for appropriate intervention, so we would like to provide evidence on this problem. Our clinical question was really simple. Which therapy is the best for patients with acute anterior shoulder dislocation? Our population was patients with acute shoulder dislocation, and we compared the immobilization in internal rotation, immobilization in external rotation, and the Bankart surgery. We have two main outcomes: the safety, like redislocation rate, subluxation rate, and instability. And the secondary outcome is the efficacy, like return to sport and scores. It's a network meta-analysis, and our hypothesis was that Bankart surgery has the highest efficacy and the lowest rates for complications in acute anterior shoulder dislocation. If we have true, we can help for the surgeons to find the best choice therapy for each patient. You can see my systematic search and my flowchart selection. My search key contains 4 domains, and I made the data search November 2023. We started around 2,000 articles, and we finished 19 eligible full text. And I would like to present my results. The first one is the redislocation rate after the intervention. We have 2 endpoints with maximum and with more than 24 months follow-up time. It's because Bankart surgery has a higher redislocation rate after 2 years. On the network plot, we can see nodes. Every nodes mean an intervention. The size of the nodes means how many studies we have about the intervention, and the connection between the nodes, how many studies work for each comparison. The league table shows us on the right corner, the direct comparisons, and on the left corner we can see the direct and the indirect comparisons to the network pool. The network pool shows that arthroscopic Bankart repair has 18 times less chance for the redislocation than immobilization in external rotation, and 8 times less chance than immobilization in internal rotation. Immobilization in external rotation has 45 times less chance than immobilization in internal rotation. The p-score shows that which can be the best therapy. It's from 0 to 1, and 1 is the best result. And we can see that arthroscopic Bankart repair has the highest p-score, is almost 1, the statistically significant and clinically relevant. With more than 24 months follow-up time, we can see the network plot is not complete, but it's not a problem because we have indirect comparisons. And on the league table, we can see that arthroscopic Bankart repair has the lowest redislocation rate, and immobilization in external rotation has lower redislocation rate than immobilization in internal rotation, and p-score again the highest by the arthroscopic Bankart repair and statistically significant again. The second outcome is the subluxation rate after the intervention. We have just one endpoint with maximum 24 months follow-up time because we don't have enough data for the second endpoint. But the network plot is complete, and the league table shows the same results as by the redislocation rate, that arthroscopic Bankart repair has the lower subluxation rate, and immobilization in external rotation has lower subluxation rate than immobilization in internal rotation. The p-score is the same. Arthroscopic Bankart repair has the highest p-score, is almost 1. The third outcome is the instability after the intervention. We measure the instability with a physical examination test we call positive apprehension test. We have just one endpoint with maximum 24 months follow-up time. The network plot not complete, but the league table and the p-score shows the same results as before, that arthroscopic Bankart surgery is the best choice therapy about these outcomes. And finally, return to sport after the intervention with maximum 24 months follow-up time. We can see that arthroscopic Bankart repair has the higher chance to return to sport on the same level, and immobilization in external rotation has higher chance than immobilization in internal rotation. P-score is the same. Arthroscopic Bankart repair has the highest P-score, almost 1, statistically and clinically significant. With more than 24 months follow-up time, the results are the same. And the subjective scores are a little bit different, because we can see that the network plot is complete, but the results a little bit different. The p-score is not the same as before, because immobilization in external rotation has a higher p-score than arthroscopic Bankart repair, but the difference is not so big. Of course, we have strengths and limitations. The strengths that we use only randomized control trials. Our participants are age-matched, and it's a complex and a comprehensive analysis. The limitations are the low number of participants, few publications to include, and missing data for important variables in some studies, and because of that, we had to make some indirect comparisons. But our conclusion is really clear. Bankart surgery has the lowest redislocation rate and therefore the highest safety after 24 months of follow-up time. And because of that, the implication for practice that immobilization in internal rotation is not recommended, and maybe we should focus on the surgery technique like arthroscopic Bankart repair. The implication for research that further prospective data collection is needed for more RCTs and more data. You can see my manuscript status, and my journal selection is the Journal of Orthopedic Translation. It's a D1 journal. And my second project is about the accuracy and consistency of 3D MRIs comparable with 3D CT in assessing glenohumeral instability. Following recurrent shoulder dislocation, up to 90% of patients may experience glenoid bone loss or Hill-Sachs lesion. And we have several imaging tests are usually used for surgical planning, like MRI for detection of soft tissue injuries and CT for detection of bone tissue injuries. But what if 3D MRI can do both? So our aim is the comparison of the accuracy of 3D MRI and 3D CT in the assessment of bone injuries after the recurrent shoulder dislocation. Our clinical question is that what diagnostic imaging tests are needed for surgical planning. The population is patients with recurrent anterior shoulder dislocation and bony lesions. The intervention is the 3D MRI, and the comparison is the 3D CT. And the outcome is the detection of presence and size of bony lesions. It will be a meta-analysis, and that our hypothesis is that 3D MRI is suitable for imaging bony defects as well as soft tissue injuries. If we have true, the clinical implication is that we can shorten the diagnostic before the surgery, and it's a big benefit for the surgeons and for the patients too. My search key contains 3 domains. We made the search in January of 2025. We started around 10,000 articles, and we are working on the full text selection now. So the summary, I hope that we can publish our first article in this summer, and our next article next summer. I have additional activities like conference presentation. On the Congress of Hungarian Orthopedic Society last year, I had an oral presentation about this topic. And last year, I have an oral presentation on the first upper limb surgery congress in Hungary. I won the first place on the Forum, and because of that, I can travel to Strasbourg and there was a conference that called IRCAD. It's the best cadaver course in the world, so it was really an honor. And I would like to thank you for your kind attention with a quote from Peter Hegyi that hope is not enough. Thank you for your attention.
Congratulations on your presentation.
Thank
I
you.
was wondering regarding your first project, is there a severity score for this anterior shoulder dislocation, or is it just dislocated or not? So how do you assess how severe is the dislocation is?
The acute shoulder dislocation is always the same, as I can say. If we don't have any bone lesion or we don't have any fracture, we treat on the same methods. So we don't have to make a severity scare because it's the same.
Okay, thank you.
We just have to make a reposition, and after that we should focus on that. How can we make the anatomy preparation?
Thank you.
Thank you for your question.
Yeah, so I guess I'll have the same question for a lot of the systematic reviews. If you go back to the summary on the first, yeah, so that your Bankart surgery should remain first, should be considered. I guess I'm interested in what is current practice in Hungary and internationally, and does this change anything? And the internal rotation immobilization, is that new, or is that just an affirmation of current practice? Either is fine, but just want to understand what's new.
Thank you for your question. It's the most important topic because now the Hungarian protocol is the immobilization in internal rotation. And the problem is that after the reposition, we just make the immobilization in internal rotation, and we said to the patients that go home, please be rest, and that's all. But as a shoulder surgeon, we know that we have a lot of soft tissue injuries, and because of that, it has a higher chance for the redislocation rate. So the practice should be that we make an operation, we screw back the cartilage, the bone, and every soft tissue, and after that, we can say to the patients that everything is okay. So because of this data, we should change the whole protocol in Hungary.
So that's fascinating. So how do you actually cascade that down to all of the shoulder surgeons or orthopedic trauma surgeons who are dealing with dislocation and say, right, the Hungarian protocol now is, because the Institute of Translational Medicine says, how does that actually work in somebody, you know, out in a farm in the country, pops their shoulder? How do they get different? How does that actually translate in the ground now that you've made this determination?
Well, firstly, I'm going every congress to say that we need a new protocol. And secondly, I'm a traumatologist too. So if I have a shoulder dislocation, or any of my colleagues have a shoulder dislocation patients, I just said that please send to me and I make an operation. So now I try to reach that my colleagues in the clinic, in the traumatology field and the orthopedic field send to me these patients, then I could make an operation.
Yeah, but you can't do every shoulder in Hungary. No?
Yeah,
I'm sure you're brilliant, but
it's a learning
lots
curve.
of energy.
Yeah.
But it's really just about, I guess my question is just policy change and dissemination. Now that you've made an evidence-based thing, are there systems in Hungary that you can do that through the Department of Health or the people who manage your health network? Is that easy to do, or are there barriers?
No.
Are there orthopedic societies that people can be influenced?
I think that maybe in Hungary we have 3 shoulder surgeon center. So it's not easy. And I think that it will be years then we can change this protocol. But because of that, when I made the oral presentation last year, it was a big success because they realized that it's important. It's statistically and clinically significant this result. So because of that, we are trying to make changes, and we try to change the protocol. And we said that we have to make an operation, especially in the young age.
So when you're, so this is interesting in a sense that when you're designing and planning to do these meta-analyses, which will have a big implication on how people are treated and how surgeons operate, the co-design of these can be really important. So in other words, stakeholder identification almost before you do it, So you say, well, okay, there's 3 places where shoulders are fixed predominantly, and having them involved in the initial protocol, it mightn't be doing much, but they can be involved in, advice. So they feel a degree of ownership, so that once you get this, they're, oh yeah, I remember that. I was there when she was starting it, and now she's coming back, and this is what she told me. So it's just a kind of that co-design and that stakeholder engagement can really make shorten the distance between your findings and the next, wine grower in your wine region who pops her shoulder, getting it fixed the way you think it should be fixed.
I think that her supervisor already did that. So there is an established way of putting guidelines into practice in Hungary. So I don't think that it's any real problem with it. And these studies actually can help in those implementations. So that this, I can't translate it to English, but there is an advisory committee for each profession for the Minister of Health. So that is quite of established way.
Yeah, and I'm really lucky because my mentor is the head of the Hungarian Shoulder Society. So
do you treat football players?
Sorry?
Do you treat football players?
Of course. I am working with the Hungarian Football Society.
Good. Because in my hometown there is one with a dislocated shoulder. Maybe it's too late.
I am waiting for the patient.
Okay, I have a few technical questions. So in your first study, you made a network meta-analysis.
Yes.
And could you check the consistency, and have you checked it?
Yeah,
yes?
We checked the consistency. We don't have enough data to make a forest plot just for the first outcome, the redislocation rate with maximum 24 months follow-up time. It was consistent, and with the other outcomes, we made an evidence plot and net heat plot, and every outcome was consistent.
And about the second question, so it was a frequentist or a Bayesian calculation for the network?
Sorry, can you...
It's a frequentist method or the Bayesian?
Frequentist.
It's a frequentist.
Yeah.
Okay, thank you. And sorry, one more question.
Okay.
In your second study,
yes,
you mentioned this word consistency. What does it mean in this matter? So for me, for a statistician, it's meaning different. In your second study, you said accuracy and consistency of the 3D and other things. So what does it mean, the consistency?
By our second study, the aim is that we make a CT, and then we make a CD picture about it. We measure the bone lesions, and after that we check the MRI and we check the soft tissue injuries. And we would like to measure the same methodology on the 3D MRI, that we can measure the same results for the bony lesions as on the 3D CT. So we have a standard methods for the 3D CT. We called it best fit circle methods. And we just would like to examine that it works on the 3D MRI or not. And that was it mean that we would like to compare this.
For me, the nomenclature for that is the agreement.
Yeah.
And the consistency. Okay, thank you.
Thank you very much.
So I wanted to ask you, I'm, not an orthopedic surgeon, so please forgive my ignorance. But I'm sort of assuming that there are more than these 3 ways to treat shoulder dislocation. So I'm wondering why you chose these three. Was it prospectively? For what reason?
We have a lot of exclusion criteria because after the first dislocation, mostly we have just soft tissue injuries. But we have bony injuries. We have to make another surgery technique we call Latagé. Then we impact bone to the glenoid, and with 2 screws we fix it. So we have to exclude every studies that had inner bone lesions, and because of that, we can measure these 3 options because we used only just Bankart surgery, the immobilization, internal external rotation. So maybe we can add the open Bankart surgery, but now it's I think it's a really old method. So in the West, just use the arthroscopic Bankart repair.
Okay, thank you. And to maybe learn more about the previous discussion about changing the guidelines, so who publishes the guidelines here in Hungary, for example, for this kind of treatment?
I think that we have to make a guideline, the Hungarian Shoulder Society, and after that, the Hungarian Orthopedic and Traumatology Society have to say, okay, we can change it, because it's in the middle of the orthopedic and the traumatology field because of its trauma, but treated by the orthopedic surgeons. So it's a complex thing.
So do you feel at this point that you are beyond equipose?
I always fight, so I tried, yeah.
Okay, thanks very much.
Thank you very much.
I was just wondering, how many patients analyzed in your network meta-analysis?
Maybe around 600. I was on the network plot. I don't remember exactly, but around 600.
Around 600, okay.
I was wondering, is this Bankart operation that every orthopedic surgeon should know, or does it require special skill or special training?
That's my other advantage for me, that it's not usually used surgery technique. So we specialize for the shoulder. Knee and hip surgeries are common things, but shoulder and elbow is a specialty in our field. So maybe in Hungary we have 20 orthopedic surgeon who can operate arthroscopically a shoulder. So
even if you change the guidelines, then many patients won't benefit from this because they have to go to trauma centers where these 20 surgeons do operate. And I believe there are many trauma centers around the country, and then many trauma centers don't have surgeons who can operate this way.
yes, we have to change on the training. So because of that, I said previously that it's a long method. It's years.
Is it hard to learn this method?
Yes,
For orthopedic
I think
surgeon?
yes.
Okay, thank you very much.
Thank you.